Dr. Amar Shah is a consultant forensic psychiatrist who became one of the most influential voices on quality improvement in global healthcare. For 15 years, he led the quality system at East London NHS Foundation Trust as the country's first chief quality officer, an organization that has been rated outstanding by the UK regulator 3 times in a row, and that the Institute for Healthcare Improvement now uses as a global reference case. In 2023, he was appointed the first ever National Clinical Director for Improvement at NHS England and awarded an MBE for services to healthcare improvement. He has just spoken at HIMSS Europe in Copenhagen, where his message was clear: organizations need to focus on creating a culture that provides people with what they need to provide the best possible care and to improve care. Amar, welcome to Tech Anatomy.
Thanks very much for inviting me.
You trained as a forensic psychiatrist and you have spent 15 years, as we said, inside one NHS trust before being asked to lead improvement for the entire English NHS. For listeners who don't know you, how does one write the quality playbook for the NHS?
Well, that's quite a difficult question to answer because there probably isn't a playbook as such. But what we do need to do is make sure that we create an environment, a culture within, the largest publicly funded health system in the world, which allows people to really focus on the things that matter most to them. And I think if you really allow patients and staff to focus in on the things that they know will make a difference for people's care and people's experience and their outcomes, that's probably how you provide the highest quality care. Now, that's not easy because you have to balance the need to achieve targets, maximize productivity and efficiency with giving people autonomy and permission to be able to focus on. So often the little things, the small things that people recognize really adds value to people's care and experience, or the little things that just don't work very well and people know that they can improve. So actually, if I think about it, really there's only a couple of things to really focus on. One is leadership behaviors. So how do we as leaders behave and create a climate within which all of our people, the hundreds of thousands and millions of people who work in the NHS, feel able to speak up when something isn't going as well as it could, or when something doesn't work, and raise their ideas and know that they have the permission to be able to test changes and see if they work. That's the first thing on leadership behaviors. And the second is we've got to equip our workforce with the skills they need to improve the system. There's a specific set of skills that you need to be able to understand the complexity of the world in which we work and then to be able to change it. Now, as a doctor, as a forensic psychiatrist, I went through many, many, many years of training as an undergraduate and postgraduate. And in those days, I wasn't really taught anything about how to make sense of the complex system in which I was going to be working or how to even improve it. These days, it's a little bit better, but we have to really equip all of our staff and our patients too with those skills around really understanding the system, because it's the system that produces the experience and the outcomes. It's usually not the efforts or the inadequacies of our staff. People are trying to do the best they possibly can every day. It's the design of the system that isn't optimal. And so we need to really equip our people with the skills and the support to be able to understand and improve that complex system.
I'm really curious, when you joined the East London NHS Foundation Trust in 2011, what was already working and what did you have to build from scratch?
So when I joined, it was a relatively small organization. It had about just under 4,000 staff. There were some really good strengths in the organization in that it had always had a very strong emphasis on clinicians being leaders. So a lot of the leadership roles were fulfilled by people who really understood the work. And I think that's so important to make sure that people who understand the work, the clinical voice is really strong and loud in the organization. They also had some other really great attributes. They were very strong on patient voice, and they'd already found ways to make sure that patients were represented in committees and decision making. And they were starting to do that at much greater scale. And then the third thing is they were very focused on teams. And actually one relatively unique thing, even back in 2011, was that every team was encouraged to take time away from work every 3 months, just to sort of reflect, plan, think, build relationships, that ability to sort of step away from work occasionally as a whole team, think about how you're working together and plan ahead for the next few months. That's so critical as well. So those are some of the strengths that we needed to build on. But there were a lot of gaps too. The focus of the organization was very much about meeting targets and really focusing on where they were not meeting targets, that assurance approach. Are we meeting the standards and meeting the targets people expect from us? It's a very simple question, but it only has two answers. Yes, we are. No, we're not. And then you focus your energies on the places that are struggling. And that's a deficit-oriented approach. It's focusing your energies on the places that are struggling. Whereas what we started to do was introduce an improvement approach, which is let's learn from the whole variation that exists and pay as much attention to the great places that are doing amazing things as well as the places that are struggling. And let's really bring everyone together to try to solve problems together. So that we introduce this approach of quality improvement as a way to harness the energy and interest of people to provide the very best quality care and to skill them up in that and to provide them with support. So there were lots of things that were already working well. And I think our hallmarks of well-run healthcare organizations, which is the clinical voice is really strong. Teams have time and space to reflect and think about their relationships and how they work together. And the patient voice is also really present and strong. And we've obviously continued to build on that over the next 15 years, as well as really expand the way of thinking about quality beyond just assurance to also think about improvement.
It's crazy that you talk about involving as much patients back in 2011. This is something that feels quite new here in France today. And you're mentioning it as something that happened already more than 10 years ago in your place.
And I think mental health services are a little bit further along with this. So, there's always been a history of working together, of shared decision-making and co-producing care plans in mental health. And so it's not surprising, even in England now. I think the mental health sector is further along in really involving patients, not just in decision-making about their own care, but also in helping run the organization. Now, if I look at how far that organization has come 15 years later, every single job interview has a patient on the panel. Now, for me, that's really unique, including the chief executive. There are patients involved in recruiting every single member of staff. All of our training is delivered by staff and patients together so that we can learn from both perspectives. Even things like business cases, commercial tenders, all of those things, research, improvement, all of those aspects all have patients involved. So there's hundreds of patients every day involved in different aspects of how the organization is run. And that's what a real co-production of health looks like, I think. And still a long way to go, but I think it really shows what we can achieve if we open up the doors and invite their lived experience into helping us think differently about the work we're doing.
We talked with Hal Wolf a couple of days ago, the president of HIMSS, and he was mentioning that during the event, one of the topics was AI, and AI again. I know that your team ran an experiment on generative AI for quality improvement. Can you walk us through what you actually tested and the outcomes?
Yeah, sure. I mean, yes, it's no surprise really that artificial intelligence was the key theme at HIMSS this year. We did start testing the use of generative AI in quality improvement work 2 years ago now, and we published that paper last year. Essentially, what we were trying to learn about was, could we find ways to strengthen the structured approach of solving a complex problem by testing the use of generative AI at different stages of the improvement process. So we equipped our team with a range of different generative AI tools. We asked them to run some tests when they were working with a team on some quality improvement work and to capture their notes about what worked and what didn't work and which prompts were most effective, etc. And actually what we learned was that there were aspects of quality improvement which generative AI tools were still not really well equipped for, but there were some aspects where actually it did seem to offer some value. Obviously, this was 2 years ago and the technology is already progressed massively, but it's probably not a huge surprise that at the stage of quality improvement work where you're looking to really build a theory, how do we solve this problem? And has anybody else ever solved this problem? And what can we learn from other places that might have solved this problem? Now you don't need to go to the library and do a literature search for the evidence base. You could use a generative AI tool and access the benefit of the large language models to actually do that so much quicker. So actually there's a really big opportunity to harness the knowledge that exists on the internet in building your theory about how would I solve this problem in my setting. Well, let's learn from what else has been shown to work anywhere else in the world. And there are other simple points at which actually it can be a really helpful prompt. Lots of people really struggle with the measurement side of quality improvement. How am I going to measure change? And actually you could ask any generative AI chatbot to say, look, this is the problem I'm working on. Here's the aim I've set for my project. Can you suggest to me a measurement plan? And it will come up with a very good first draft. As with all of these tools, they're just drafts, and you need the human and the contextual element to be added onto it to make sure it really works and fits for your setting. But it was pretty good for those particular two aspects. It was less good 2 years ago at visualizing things. And actually, quality improvement is a very visual field of applied science. We like to draw things. We have lots of charts and images. It wasn't so good at creating those, but even in the last 2 years, the technology has moved on so far that actually now you can actually ask tools to create visual tools like driver diagrams, like run charts, like Pareto charts, and it does a pretty good job now. So I think it's there as a tool. Most of us have a generative AI tool in our pockets, in our mobile, and actually, it's very accessible to us. So why wouldn't we use it as a way to sort of start to really strengthen aspects of quality improvement? It will never remove the need for that true experience that comes from people working in the service or people receiving care from that service. You'll never replace that, but it might be able to add something from what's happened elsewhere in the world. It'll give you some prompts that will just help you make quality improvement a little bit easier for people to do.
And I know that one of your concerns is that Gen AI may create these disparities between people or even healthcare facilities. What do you mean by that? And how does that impact the way you choose your tools and your providers?
Well, I think we should always be alert to inequities. I mean, they exist. If you just go looking for them, they already exist in terms of different groups of people have different experience of care. They have different outcomes. There's different access. And actually, once you start looking into your data, you'll find that they already exist. The question is, are we alert to that every time we're trying to improve the system, every time we're trying to redesign the service? Are we alert to it so that we're paying attention to it? And we can make sure then that when we introduce change, that it doesn't make it worse. And generative AI is just another type of change. If we introduce a technology tool like Gen AI, we just need to be alert that, the groups of people who are already experiencing worse outcomes or worse experience or have poorer access to services we don't widen those disparities. And there are real risks to generative AI. I mean, these models have often been tested and validated on large volumes of data. And so we think they must be accurate, but actually they're only as accurate as the data on which they've been tested. And if you look at some of the tools that are being tested on, the really big biobank data and genetic data, they don't represent the true breadth and diversity of our society. The UK biobank, I think, has only 1% which are non-white, which, for me, that really means that we have to be very cautious about a tool that's not been tested on the actual diversity of the population, because it will miss things and it will potentially widen disparities because it won't necessarily detect things that are relevant for the populations we look after in our local communities. And, where I work in East London, we have 100 different languages spoken. We need to be making sure that the tools we apply have been tested locally. So I think we just need to be alert to it. And we need to run more experiments with our local population and not just assume that a tool that's been tested and validated at scale with some of these really big databases are therefore valid. I think if we looked a little bit closer, we might find that they're not truly representative of the breadth and diversity of people and how they present with illness and symptoms. And we want to make sure that the tools are going to help us rather than offer blind spots that we're then going to miss and widen the inequities that already exist in our society.
One of the things that you've been experimenting with are AI scribes and ambient documentation, partially because it can be a solution to burnout, physician burnout. There's a study that was published in October of last year that found that burnout dropped from roughly 52% to 38% in just 30 days using this type of tools. What is your read on the evidence so far, and what's your experience with that?
Well, I think the first thing to say is in health systems, in most places in the world, our interaction with technology is not usually a positive one. It usually takes attention and energy away from what actually adds value for patients. And often the number of clicks and the number of times you have to write things in and often duplicate things is a burden. It's a very real burden. And actually, we're talking about AI and all these amazing technologies. Just sometimes the basic things don't work very well in healthcare systems. And often these electronic health records are not really designed to optimize the experience of the clinicians and the staff. And they really ought to be. So anything, I think, that can reduce that burnout, that burden is a good thing. So I'm really pleased that the use of scribes has started to reduce burden, both physical burden and also emotional burden for people. But it's not enough. I don't think it's enough. The scribes haven't been shown to improve productivity yet, but I don't think that's necessarily a detraction, because simply removing and reducing emotional burden and burnout is a worthwhile goal in itself, but it's not sufficient. And I think there's lots of things that contribute to burnout in the workforce globally. The use of technology and computers and typing notes and using EHRs is just one aspect. There's also a whole load of other things that teams can actually have some control over. A lot of my work has been in this field of really enhancing joy and putting joy back into the workplace. The absence of burnout does not equate to joy. A lot of the early research, shown us that there are things that we need to really work on to reduce dissatisfaction and burnout. These tools may well help us with that, but we have to do other things to actually create motivation and satisfaction and then generate joy in the workplace. And so for me, this is one of many things that healthcare organizations should be thinking about. If they really want to create a joyful workplace, we need to then think about, teams and how well teams are working together, the communication, the rotas. What are the things that the teams have control over that they could actually change to make their days a more meaningful one, where they're actually spending more of their time doing the things that they actually came to work to do? How do we appreciate each other more? How do we involve people in decision making? All of those aspects which really then create a thriving workplace.
And you also wrote about learning to forget, which is retiring outdated practices to make room for new ones. If you had to name, let's say, 3 things from the NHS that they should stop doing in order to make AI, automation, and tools that work and bring joy, as you said, what would that be?
So I think the first thing I would suggest we have to forget, or at least stop doing, is to assume that things can simply be rolled out. This phrase rolling out is one of my bugbears. It really doesn't suggest people understand how to implement and scale in complex health systems. Instead, we need to really learn very carefully in prototype and test beds about what it takes to optimize the use of technology or a new change in practice. We need to capture that. We need to demonstrate the benefits of it. And then we need to scale deliberately, allowing people to adapt and test in their own environment. The concept that you can just simply roll something out across an environment as diverse and different as the healthcare system tells me that leaders just don't understand the complexity of the world they're working in. So rolling out is something we should only ever do for a carpet. In healthcare, we need to test, adapt, and learn. And that's, I think, the best way to make sure that people really make the technology work for them in their environment, with their local culture and context, rather than simply drop it from on high And then people have to do the best they can with something that hasn't really had the opportunity to adapt into their environment. That's the first thing. The second thing I would say is we shouldn't assume that technology by itself will make things better. Technology is it's an enabler, but actually we need to focus on the outcome. What is it we're trying to achieve? And technology will be one of many things that might help us achieve that. But if we lose the focus on the outcome and think that technology is the outcome, we're sort of missing the point completely. What is the problem we're trying to solve? What's the outcome of interest? Then how do we look at the full breadth of things that we'll need to do, including technological changes, and then test and learn and adapt in our environment to really make it work for the people that receive care and deliver care in that particular environment. So 2 things, I think, not 3, but 1, let's avoid the temptation to just think we can roll out quickly and at scale. It won't work, because all of implementation and improvement science tells us we need to test, learn, and adapt. And the second thing is, let's treat technology like a change concept, alongside many other change concepts aimed at achieving a goal.
I believe there's a similar challenge with data as well, because we have so much data in healthcare, and yet most clinicians don't really see the impact on outcomes on their practice. What does it take to really harness the power of data in a useful way so that people delivering care see the impact?
So my view is that healthcare perhaps has some of the most complex data systems of any industry. In my time at East London, I took on the executive lead for data and analytics 8 years ago now, and it was sort of a real eye-opener for me. We already knew how important data was. If people and teams were wanting to improve, they really had a hunger for data, and we weren't able to give them it as quickly and easily as they needed it. So that's why I took on the leadership of data, and I then started to learn just how complex this world is. We need to do 2 things. First of all, we need to make sure that our data at the back end, the end that nobody sees, all of our data in healthcare is somewhere, it's stored in some kind of data warehouse, some kind of big giant database. Often it's on a server on someone's office, but nowadays it should really be up in the cloud where it's much more secure and available and accessible. We need to make sure the data all maps back to teams so that as a team, I can see my clinical data alongside my safety data, alongside my finance data, alongside my workforce data. Now, it sounds very simple, Anka, but I can promise you most organizations do not have their data mapped back to team level because they're all different systems and they've all been set up separately and they don't map back to a team. And actually, as a team, what you want is you want to understand how you're doing by looking across different things. You don't want to go to 10 different places to see your data. You want to go to one place and you want to see how are we doing across these different things in a simple way. But to achieve that's hard work, to really map it all back to a single team. And then be able to aggregate from there is a big piece of work to do. And the second thing then is we need to design analytics that answer the questions that our teams have. And you need quite a bit of skill to go to a team and say, right, what are the decisions you have to make every day or every week? And what data would really help you make better decisions? And then we as experts in data, we will figure out what is the data that exists? How do we present it to you in a way that helps you make better decisions and is really accessible for you? So I think those are the 2 things. One is organize it better, wrap it around teams at the back end, which takes quite a lot of technical work. And the second, really design analytics to be able to answer the questions that our clinical teams need in order to optimize the care they're delivering.
I just want to jump on that because sometimes we work with our own clients on identifying, let's say, generative AI use cases for their teams and their companies. And, this approach of co-designing and identifying the use cases together is what you're describing. And we go to them and say, what are the use cases that you want? Where do you need help? But sometimes what we realize is that they have an idea of where they need help, but it's always useful as well when we come with ideas they don't even know existed, and they don't even know that it's possible to do such things, so they don't even talk about it. How do you manage this balance between co-designing with the teams and also bringing new ideas in?
Yeah, it's a really good question. And you have to have a balance. You can't just allow the clinical teams to design whatever they want, because you're right. Often they don't even know what data exists. So they wouldn't know what the art of the possible is. And also every team may want their data presented differently. And actually that's not a very good design at enterprise level. So you have to have some principles. And we began by sort of setting out some very clear design principles that, one of them was that we were going to build from the team up. We weren't going to start at the top and then work down. We were going to start from teams and what teams want and need, and then work up from there. The second was we were going to embed improvement science principles. So the way people saw their data was all about understanding variation. How are we doing over time? Are we getting better or not? How do we do compared to others? Those questions about variation, rather than are we meeting a target? Yes, no. We didn't want to give people the data in a binary way. We wanted to help them learn about variation. And the third was we wanted to make it fully accessible. That was another design principle. So that, data can be a very big reinforcer of power hierarchy in organizations. The managers, the senior people, they have access to data. The people actually on the shop floor doing the work don't have access to data. That's not right. So we wanted to really make sure that all the data was available and accessible to everybody. And that was a really important design principle. And it does change the decisions you make about, where does your data sit in the cloud or on a server? If it's in the cloud, it's accessible from anywhere, from any device, anytime. Do you use different types of front-end analytics tools? Some are much more able to be scaled at low cost than others. I think it does influence the decisions you make about the technology you use and how you design this. But then you need to sort of have some very clear questions and sort of skill around the co-design aspect. The co-design aspect is let's make sure that the analytics really helps you make the decisions you need for your patients. There is some customization around that. There's no sort of customization around the design principles. If you look across the 30 odd apps we've built for our clinical teams, you'll see the data presented in a standard way. And that's important. That if you're working in an older adults team, or you're working in a children's team, or you're working in an HR team, you'll have different questions, but the data will be presented to you in a similar way. And that's important because it creates a language, a way of talking, a way of understanding, that's consistent and creates a common language in the organization. That's a pretty important thing to keep.
And if leadership team came to you and asked, what type of question should our data answer? What would your short list look like? And what are some of the most important things that they need to have in mind before starting?
So I think the questions a leadership team should be sort of keeping in mind are, do we have a small number of whole system measures that we use to understand the performance of the whole healthcare system, the organization? Usually the answer is no. We look in lots of different places and there might be hundreds of different things we feel like we need to keep an eye on. Actually, the best places narrow that down to perhaps 30 indicators, and they look at them consistently and they give them a rounded picture of how is this healthcare organization doing. That's the first question. The second question should be, do we really understand the variation? If you simply look at the data aggregated at whole organization level, you're going to miss the variation. So can I see the variation that exists? Who's doing this really well? If you take any one of those 30 metrics, who's doing this really well and who's struggling? And because part of the art of leadership is to learn from both. And then the third question they should be asking is, how accessible is the data to our teams? Can our teams see their own set of metrics, maybe 10 or 15 things that they really care about, a rounded set of metrics, not just safety things, but safety, quality, workforce, finance, the whole range of things that they need to look at. Can they see their own data easily? And do they use it as part of their sort of regular rituals and routines in a team? I think those are the questions the leadership team should really be asking. Usually there will be work to do. And most of those don't really exist in big, complex healthcare systems yet. So And my honest opinion is this is not a technology issue. And often we treat data like a technology thing. And it's usually not a clinician who owns the data system. We often give it to IT, or we give it to the chief data officer, or we give it to chief digital officer. Actually, for me, it's been really interesting to be the clinician in charge of data. And I think it really changes the way you view it and how much importance you put on it when you have a clinician at executive level responsible for data in the organization.
And my last question to you, you stepped down from your role at East London after 15 years in the organization. What are some of the lessons that you want to embed across the entire NHS, and what are maybe the things that you would skip?
Some of the key lessons have been about staying true to a mission for a long period of time. So that real constancy of purpose that W. Edwards Deming, one of the forefathers of the quality movement, talked about. If you really want to create a culture that's focused around quality, then you have to stick at it for a very long period of time and not allow yourself to be distracted. That's something that I think we've been very fortunate to keep in East London. Despite I worked for 4 different chief executives in that time. But the commitment to quality was there throughout. It didn't matter who the chief executive was. In fact, we recruited to the CEO role based on their commitment to quality. So I think that's like a really important thing. People come and go. They will, you have to expect that people will come and go. You can't hope to retain this approach just by people staying for a long period of time. But you'd hope that the culture retains because of the commitment to it and the results that it achieves. The thing that probably I would try not to scale is assuming that a recipe that works for one place will just work everywhere. Like I said earlier, I think you have to allow every organization to take their own path. Everyone's starting in a different place, has different strengths and assets to begin with. Maybe they want to try a different approach or a method. Their people and culture and communities are different. So I think there's a lot of merit in people owning this journey for themselves. The more people own this, the more likely they are to really, truly believe it and commit to it and continue it, even when times are really tough, as they are in most healthcare systems at the moment. So that's what I would keep and what I would perhaps think about and not trying to replicate.
Well, thank you so much, Amar, for taking the time to answer our questions.
You're very welcome. Thanks for having me, Anka.
And thank you, dear listeners, for following us on this episode. I will see you soon on Tech Anatomy.